Thanks. I think we are very late actually. So I'll just try to be as brief as possible. First of all, I bring greetings to all of you from India, from New Delhi. Dr. Akrob has actually made my job a little easier, and he says that product control is better and transplant should be limited to very, very selected group of patients. In fact, this slide summarizes the philosophy of treatment of myeloma. The goals of treatment in myeloma, first is really to control the disease, achieve sustained response, CR, near CR or BGPR, and which hopefully translates into the improved survival and possibly a small fraction may get cured. And this is actually really the summary slide. Now, the current management of myeloma stands initial therapy, induction, and followed by consolidation with transplant, as he said, and maintenance. And let us see how really we are going through these. This is the algorithm which he proposed and which Professor Q also mentioned, that how we really are approaching these patients of myeloma. The young patients, give induction, responding, go for transplant, less than optimum response, second line, then evaluate, responding, go for transplant. But and these are some of the regimes which have been summarized in front of you, and these are some of the recent regimes which are, you can see the response rates in the near CR or BGPR in the first line following the induction therapy. Now, transplant was one of the options earlier when the response to the induction therapy in the pre-novel agents era was less than 15% of CR or BGPR. But now once we have these high response rates with almost approaching from 50 to 70% with the induction therapy itself and transplant adding a little bit to this, we have to always ask the question, do we really need transplant for all patients or not? And this is one of the recent report again, confirming that you can achieve CR with induction therapy in almost 35% of the patient with the 3-drug combination and with about 20% in the 2-drug combinations. Now, one of the question which was put forward was that whether we can really do the transplant for all patients. We know that myeloma is a disease of old age. We have almost 37% of people in the Western world who are above 65 years, where they're doing transplant above 75 years, in fact, and another 26% with above 65 to 75 years. So if you summarize, total it, so you only have really about less than half of the people who are so-called young, who qualify the definition of the transplant eligible patients. So therefore, you really need the regimes, the induction therapy, the different regimes, the different combinations, and some of these which have been summarized here. So one of the lacuna in the literature today is that we do not have head-to-head comparison of the 2 drugs, 3 drugs, or 4 drugs. Thalidomide dexamethasone versus Len-dexa versus bortezomib-dexa. Unfortunately, we have a comparison between the bortezomib-dexa versus Thal-dexa, but not between the 3 at one go. And this is one of the such study which we are doing right now. We have recruited 100 patients, and this is data of the initial 69 patients, which clearly shows that there is really no difference if you use between Thal-dexa versus Len-dexa. The complete and very good partial remission rate remains almost same in both the arms. And so is the overall and the event-free survival. So therefore, there is really need that we really need to carry out such a study where we can really compare the 3 different combinations. But I'm not sure, Simrat, whether this will be one of the topic for one of your the programs which you are thinking for that the Asia Pacific Hematology Association, which can really take up this kind of work. But now with the new molecules coming up, I'm not so sure. So therefore, to summarize that currently it's possible to control myeloma, whether you use 2 drugs, 3 or 4 drugs, The response rates are higher if you use more drugs and possibly the progression-free survival. However, we still have doubt whether the overall survival is improved except in very few studies. And more in the number of drugs, the chances of toxicity are also higher. Therefore, there is always suggestion that whether we can use the risk-based approach or patients depending on the patient preference. And one of the such approach which we have adapted, and we have carried out a study, and we in almost 90 patients. And what we did that we did the cytogenetics on them, and we try and along with the ISS, and we feel that if you combine both deletion 13 and ISS staging, and you develop a scoring model, which probably can give you one of the simple method to really divide these patients low risk versus the high risk, which can clearly tell what the response rate as well as the overall survival and event-free survival is different in the patients who are low risk according to this model compared to those who are high risk. So this may be the one simple strategy to randomize your patients from the beginning itself and to treat with the induction therapy, whether you want to give 3 drugs or 4 drugs, comparison to the 2 drugs. And the other thing, like if you achieve complete response with your induction therapy, even though this study which we have recently accepted in the clinical myeloma, just last week only, we have analyzed the data of 170 patients who received the induction therapy, all combinations, alkylating agents, VAD, and in last 66 patients received the novel agents. And what we have been able to show that those who achieved CR and both due to induction as well as the transplant, they have a long-term survival, both overall as well as the event-free survival. So therefore, the patients who achieve CR with your novel agents therapy, probably you don't need a transplant for them. You can just continue the maintenance, the way we have been doing. The number of options are available, which I have discussed. And with their relapse, then they can be taken for transplant. But those who are less than optimum, less than your BGPR or partial response, probably you may like to consolidate them with the transplant and go for maintenance. So this could be one of the way. So therefore, to summarize between the two, the transplant has its own limitations. It can be offered to very young patients because of the age, which is less than 40% of the whole population. Patients who have renal failure, again, they have high mortality. Again, they are not the candidate for transplant. Patients who we also have to realize that the morbidity and mortality of transplant can vary from 1 to 3% in the standard risk. And those who are high risk or elderly, their mortality can go even 5%, even a little higher. Again, the morbidity of transplant with double transplant can again be higher. Allogenic transplant I have not discussed, but again the morbidity of the complications of allogenic BMT can be again very, very high. And of course, not forgetting the relapse. And about less than 2% of patients may not mobilize also while we are doing the transplant. So transplant is not something which is panacea in multiple myeloma. So what we really need is the good control of the multiple myeloma so we can really maintain the good quality of life in these patients. Thank you so much.
Right. Any questions from the audience?
I have actually questions for Dr. Kumar, Dr. Lalit Kumar. So there are 3 questions actually. One was you had mentioned Thal-dexa versus Len-dexa,
yeah.
And more than VGPR, you're getting 32% in Thal-dexa and 34% in Len-dexa. Now traditionally, do you have a breakdown of how much CR do you have with Thal-dexa?
This is about nearly 15%.
15?
Yeah.
Which is relatively high compared to any published data because usually it's in single digits.
This is CR and near CR actually.
Okay. And you know, and how much was it in Len-dexa?
About 17%.
Okay. Because, you know, this is one of the things that even when you look at the traditional studies with Thal-dexa, although overall response was 60%, but, you know, the CRs and VGPRs were always very dismal.
Yeah, we have used the low-dose dexamethasone for both Thal-dexa and Len-dexa.
And what's the dose of thalidomide that you're using?
100 milligram per day. Okay. We normally give for first 2 weeks and try to build up to go 150, 200.
Okay. Now, number 2 question that I have, you had made a reference that renal failure patients may not be eligible for transplant.
Yes.
In fact, in our center, it's the opposite. If you are renal failure, and especially if it's because of myeloma, it's all the more reason to go on to transplant. And in fact, I just transplanted a 72-year-old, and he was dialysis dependent, and now he is not requiring any more dialysis. So what is, I mean, the difference? Like,
Well,
is it just
in
because
renal failure, you have 3 subsets of patients. Set number 1, those who, after the initial induction therapy, and one of the combinations like bortezomib and some of those similar combinations which can be used, and they achieve the normal renal functions, they have a similar outcome to like normal standard myeloma. Second, the patients who have improvement renal failure but not complete, they may have like 2.5 or 3 milligram creatinine. I would be more comfortable doing transplant if I have to do them for patients who are 2.5 or between 2 and 3. Above 3 is something really mortality can be high. In fact, one of the paper by one of the initial papers, they even had mortality of almost 19%.
Yeah.
In those cases.
So we have like less than 1% in those patients, and in fact, we don't do any dose reduction either for
actually those who have normal renal functions, then you go like standard normal transplant, 200
patients on dialysis,
square.
that's what I'm talking about. Patients who
well,
are
you need a very good coordination with the dialysis team,
yes.
So it has to be next door so that you can transfer,
absolutely
which
correct.
can be very difficult in any of the busy hospitals in city like Bangkok or like in New Delhi.
Well, New Delhi is at the forefront of medicine. Now, the third question I have is, you mentioned that patients who go into CR or VGPR or stringent CR, they may not need transplant at all.
Yes.
Now, I mean, this is a big controversial topic because we think that if you have gotten a CR, it's all the more reason to go on to transplant so that you can consolidate that response. So in your practice, do you harvest and save, or how do you stratify these patients?
Well, we do not really harvest and save because of logistic issues, but that may be one option, as you said. But I feel since if you are able to achieve good quality CR these days with some of the combinations of 2 or 3 drugs or 4 drugs, whatever you're using, you probably can delay the transplant, so you can really delay reduce the morbidity and so-called risk which may be associated with the transplant in these patients, and can do the transplant whenever the patient relapses. The reason I'm saying that I have not shown you the data of these 170 patients, actually the reviewers asked us to reanalyze the data on the novel agents. And we had 66 patients, and when we did the interval analysis, the patients overall for the whole group, those who underwent transplant within 12 months, there the outcome was superior compared to who underwent after 12 months of the diagnosis. But when we analyze this data for the patients in the novel agents who received the induction therapy, there really was no difference. So if you really do transplant early or late in the present era, probably it does not make any difference. So in that case, you don't have to really push for transplant in the beginning itself. That's what I feel.
So just one additional point on that I agree with all you said, but in terms of stem cell mobilization and collection, the more treatment a patient has received, you will have more mobilization failures, more evolution of disease into a more advanced stage with adverse chromosomal abnormalities. So those things, I believe, have to be taken into consideration. Control approach, the way you put it, is fine, but those are obviously the things.
Yeah, absolutely. Agree. Thank you.
And in your curative approach, is there a particular group of patients, say if you go by cytogenetic abnormalities or risk stratification or age, or any particular patient that you would go for cure as opposed to control when you see a new myeloma patient?
The practice of our institute is to, if the patient is a candidate for transplant, and because of the availability of the resource in our country, we want to push the patients into the transplant. Okay, because we still believe that if the patient has chance to enter the transplant unit, the outcome is better.
Sure, but people would argue with you based on data that it's not universally true, right? Okay. All right, if no other questions, then we can move to the next session. Okay, great. Thank you.